All right, welcome to our deep dive into the high-stakes world of neuroanesthesia. Today, we're going to walk through the absolute essential principles you need to know to protect what is arguably a patient's most critical and fragile organ, the brain.
So here's our roadmap for today. We're going to start with the fundamental rules of the brain's unique environment, then dive into blood flow dynamics. After that, we'll look at the physiological levers we can actually pull, see how our anesthetics fit into the picture, and then wrap it all up with a practical neuroprotective strategy.
Okay, first things first. We have to really appreciate the unique and, let's be honest, pretty unforgiving environment we're working in. You see, the skull isn't just a helmet. It's a closed, rigid box with some very, very strict rules.
And this is the absolute cornerstone of everything we're about to discuss, the Monro-Kellie Doctrine. Just think of it as the rigid box problem. The total volume inside that skull cannot change. So if something swells, like the brain tissue, or mass starts to grow, something else has to get squeezed out to make room. If it can't, that pressure doesn't just go up a little, it can absolutely skyrocket.
This chart here really breaks down what's inside that box. You've got three things: the brain tissue itself, making up about 80%, then blood at 12%, and finally cerebrospinal fluid, or CSF, at about 8%. So when the brain swells, the body's first move is to try and compensate by pushing out some of that CSF and venous blood. The problem is, that's a very limited buffer. Once you run out of room to compensate, even a tiny bit more swelling can cause a massive, dangerous spike in pressure.
Now, here's why that pressure balance is so incredibly critical. The brain is, for lack of a better word, a greedy organ. It uses a whopping 20% of your body's total oxygen, but here's the kicker. It has almost no ability to store energy. What does that mean? It means any interruption to its blood supply has immediate and potentially devastating consequences.
Okay, so let's build on that. Now we're going to get into our central mission as anesthesiologists, which is making sure that this incredibly demanding organ gets the constant supply of blood it needs to survive.
And that brings us to this simple but absolutely vital formula: Cerebral Perfusion Pressure, or CPP. This is the actual force that drives blood into the brain. You calculate it by taking the mean arterial pressure, your MAP, and subtracting the intracranial pressure, the ICP. This single number, CPP, is our North Star for figuring out if the brain is getting enough blood. And this table right here, this is where that simple math gets really, really real. You can see as that CPP drops below 50, the EEG starts to slow down. Between 25 and 40, it goes flat. And if you dip below a CPP of 25, well, you're in the territory of irreversible brain damage. Our entire job is to keep our patients away from these numbers. But here's where it gets nuanced. You see, the brain has this really clever trick called autoregulation, where it can maintain a steady blood flow even when blood pressure goes up or down. But, and this is a big but, in a patient with chronic hypertension, their whole system is shifted to the right. Their brain is just used to higher pressures. So a blood pressure that's perfectly normal for you or me could actually be dangerously low for them, causing brain hypoperfusion. We always have to adjust our goals for that patient. Okay, so we understand the system, we get the vulnerabilities. Now let's talk about our toolkit. What levers can we actually pull to control what's going on inside that rigid box? Listen, if you take one thing away from this whole section, it's this: the most powerful, the most rapid-acting tool you have to manipulate blood flow in the brain is the patient's arterial carbon dioxide level, the PaCO2. It's like a master switch for the brain's blood vessels. And this chart illustrates that relationship perfectly. I mean, look at it. On the right, when CO2 is high, that's hypercapnia, the vessels dilate, and you get a surge in blood flow. And on the left, when CO2 is low, hypocapnia, the exact opposite happens. The vessels constrict and you reduce that blood flow. This is our go-to tool when we need to manage high intracranial pressure, and we need to do it fast. Our second major lever is temperature. And the relationship here is also super direct. For every single degree Celsius you drop a patient's body temperature, the brain's metabolic rate and its demand for blood flow decreases by about 5 to 7%. This is precisely why induced hypothermia is such a powerful strategy for protecting the brain.
All right, let's switch gears and talk pharmacology. How do the very drugs we use to put people to sleep interact with this incredibly delicate system? Because they're definitely not all created equal.
So you can basically split our anesthetics into two main camps. On one side, you have the inhaled agents like isoflurane. These are vasodilators. They actually increase blood flow to the brain even while they're decreasing the brain's metabolic demand.
We call this uncoupling, or luxury perfusion, basically more flow than the brain actually needs. Then on the other side, you have intravenous agents like propofol. These typically do the opposite. They constrict the vessels, decreasing both blood flow and metabolic rate together in a nice coupled fashion.
And in that intravenous category, there is one major critical outlier that you have to burn into your memory, and that outlier is ketamine. Ketamine is the big exception to the rule. It does the opposite of its IV cousins. It's a cerebral vasodilator that actually increases both cerebral blood flow and the brain's metabolic rate.
This table is pretty much your cheat sheet. Look at the top three: propofol, etomidate, barbiturates. See all those down arrows? They all decrease the metabolic rate, the blood flow, and the intracranial pressure. That's usually exactly what we want. Now just contrast that with ketamine down at the bottom. Up, up, and up. It increases all three, making it a pretty risky choice in a patient who already has a swollen brain.
So let's put it all together. How do we take all these physiologic and pharmacologic principles and actually apply them at the bedside to protect our patient's brain during surgery?
Okay, here's a classic real-world emergency. Your patient's ICP is spiking. What do? Well, you go right back to that PAC CO2 principle. You increase the patient's respiratory rate, you hyperventilate them. That blows off CO2, which causes immediate cerebral vasoconstriction. This shrinks the volume of blood inside the skull and gives you a rapid, even if temporary, reduction in that dangerous pressure.
And beyond those acute emergencies, these are our guiding stars for pretty much every neuro case. Number 1, maintain that cerebral perfusion pressure at all costs. Number 2, make sure oxygenation is perfect and keep CO2 normal unless you're intentionally manipulating it. Number 3, control blood sugar because hyperglycemia makes ischemic injury way worse. And finally, for the really severe cases, you always consider the powerful protective effect of hypothermia.
The good news is we're not flying blind in the operating room. We have tools to help us. A key one is the BIS monitor. It essentially takes all the complex electrical activity of the brain, the EEG, and processes it into a single, easy-to-track number. This lets us precisely manage the depth of anesthesia, keeping the patient in that sweet spot, that target range of 40 to 60, which helps keep the brain's metabolic demand low.
So I'll leave you with a final clinical question to really make these concepts stick. Based on everything we've just talked about, from the rigid skull and CPP to the specific effects of our drugs, which anesthetic would you choose for a patient with a traumatic brain injury and high intracranial pressure? And more importantly, why? Thinking through that choice is really the best way to make these principles your own.